Yeah, so today we're going to be doing mechanical thrombectomy of unprovoked left iliofemoral DVT in a patient who's pretty symptomatic. Um, Based on her CT venogram, it looks like she also has May Thurner, so that's probably the culprit. So here our goal is going to be to extract as much clot as possible using an Inari ClotTriever device and then stent the left iliac vein. So we start with ultrasound guided access of the popliteal vein. So we're just using ultrasound to find the popliteal vein, and we like to find a good spot for the 13 French sheath, which we're going to be inserting. What you often find is when their legs swollen like this from the DVT, they don't have as much pain with access. It's because those receptors have all been kind of overstimulated. All right, and so that was fairly uneventful. We use a micropuncture needle, so if you do have to restick or you accidentally hit artery, it's really of no consequence. And we just confirm our access with x-ray. So we're going to bring in the x-ray now to take a look. Perfect. Just to confirm we're in vein and see what we're dealing with. Can you put this on just a coronary package, and we'll follow this up the leg. So you can see this was all occluded downstream yesterday. And actually the femoral vein has opened up nicely. It's very helpful because now all we're dealing with is the iliac system, so it makes the procedure much shorter. All right, so we're going to go ahead and upsize to an 8 French sheath, and we'll cross through the occlusion and we'll perform intravascular ultrasound to define the May Thurner, how big her iliac system is, how much clot's there. Now, everyone has their own favorite wire to cross through blockage. I like the Glide Wire Advantage that has a hydrophilic tip, but then it's normal on the backside. So it doesn't spring back on you, and it's easy to control on the backside. Can I get a little introducer? All right, show me down. Let's just make sure perfect. All right, you can follow me up. The beauty of fresh clot is that it's usually pretty easy to cross. I'll take that Navicross catheter. Now the wire flew right up to the spot of the May Thurner, which is the compression on the iliac vein, and so we're going to need a little support behind the wire to get it to cross into the vena cava. So this is a Navicross catheter. It's a braided tip hydrophilic catheter with an angled tip at the end, about 1 centimeter. So it allows you to direct this wire. And these cross very nicely through these stenotic vein lesions. We're going to take this up to the common femoral vein and take a more selective picture. So you can see we have occlusion at the external iliac vein and with collateral flow. All right. Breathe normally, dear. Good job. Nope. We'll cross through the occlusion and then confirm we're in the vena cava. Okay. I'll flip this. We hope. Can I get a torquer? That's okay. Can I just make sure we have a straight glide wire available? Yeah. Short will be fine. So, you know, her iliac's probably been narrowed or closed at the May-Thurner site for a while. And then she finally just closed off, clotted off her leg. So I'll take that straight. I'm going to need it. So this is the straight glide going in. And so we just hope to pop right here into the vena cava. And it looks like we did. Follow that up. So that's good. Come down a little bit. We're going to confirm we're in the vena cava. Excellent. Beautiful. Alrighty. So we cross through. We'll take the glide wire advantage back. Now, for the Inari ClotTriever device, you need wire all the way up into the internal jugular if you're cleaning out the iliac system, and that's because of a basket, which we'll show you on the device, that trails behind the what we call the coring element and catches the clot. It's pretty long, so you need a lot of running room. So you can put it down the arm or up the jugular. I just like the jugular because it's a straight shot. So this is an Amplatz, super stiff wire. They come in, they all have soft tips on them, even though the wire is really stiff. And you can get a 1 centimeter soft tip or a 7 centimeter. I like the 1 centimeter. Some people like the 7 centimeter. I think it's just preference. But you need a stiff wire to get the Inari device to go. So that's why we use the Amplatz. Now this May-Thurner is pretty tight. The IIUS may not go. But we're going to try an IIUS up front. I think it offers some advantages. It makes sure you're not in some small collateral. You can sometimes course into paraspinal collaterals and things like that. And it gives you an idea of how much thrombus is in there. So this is the 035 intravascular ultrasound catheter, which we're going to take up and investigate her iliac. So we're going to record from vena cava down. And you'll see right at the proximal common iliac vein. So there's at around 12 o'clock, here comes the artery crossing over the iliac vein, and when it does that, it closes the vein. So she has, you know, the classic findings of May-Thurner. And we have some stenosis that extends down. Then we have a lot of clot. Perfect. Good. We're in good position. So this is the Inari sheath that we're going to take the device through, and it's 13 French. What's special about it, and this is how we deploy it. Once we put it within the body, we advance the dilator, and that exposes a funnel, which we need for the device. When we pull the device back, this funnel is going to catch any clot that pulls in to the sheath. And we take the dilator out, and that leaves this funnel behind. And it'll catch any clot, and at the end, when we pull it out, the clot will be stuck in here, and it will come out with the device. So sometimes if we put this sheath into the popliteal vein and it's full of clot, then we have to actually balloon the popliteal vein open a little bit so the little funnel in the sheath will expand. Sometimes we have to balloon before we even put the sheath in if it's super tight and chronic, but that's not going to be the case here. A lot of pressure, okay? This is normal. This will be the worst part here. Good job. Hold wire. Okay, step the dilator out. There's a bleed back button on the back of this sheath, so you can see how briskly it's bleeding back. We know that we're in vein that doesn't have clot in it, and that's good. So this is the Inari ClotTriever device. It comes in one size. Here, let's do this. This is when the device is fully open. So the device has a coring element that pulls clot off the wall of the vein, and then it's caught here within the windsock behind the coring element. And you can be directional with it. Actually, you can turn the coring element, to wherever the clot is. Now, we have complete occlusion here, so it doesn't matter on our first couple passes, but after that it may matter a lot. And so the beauty is you can be directional with it. Obviously, the other fantastic thing about the device is it doesn't require lytic therapy. So you eliminate all the risk of lytics, and it still does a very good job removing clot. In fact, it's a very efficient device. So you get efficiency, you get excellent clot remover, and you don't run the risk of lysis. So this is our preferred device for the treatment of iliofemoral DVT. All right. So we're going to go in with the device. Now on the screen you'll see a radio-opaque marker. So you want to take the radio-opaque marker past all the clot. So for us that's going to be all the way into the IVC. And if it has any trouble, then we can always balloon the May-Thurner segment. It's really tight, actually. So what I may do, step this back. Come back, come back, come back. Yeah, let's go here. All right, hold the wire. Because her iliac is so tightly blocked, I'm probably going to start by pulling clot down more distal. Can y'all find me just a 10 by 40 balloon? Hold here. So once you have the radio-opaque marker to where you want it, you've exposed the device, then you just open the coring element by pulling back on this handle and turning it towards you. And this is what the coring element looks like when it's open. That's actually going to end up being sort of distal to where we want to pull. But on ultrasound, even though by venogram it looks pretty good, by ultrasound there's still some clot in there. So we'll pull through this one time and see if we get anything. Yeah. You're going to feel some pressure, okay? That's normal. Now I have a trick where I like to relax my coring element a little bit through smaller femoral veins. And so basically I release the device handle, but I put a hemostat at the mid segment of the handle, if you can see that, so the device doesn't fully relax. So it's not fully open, but it doesn't fully relax either. And then we'll just pull, see if we get anything. And then her May-Thurner is just so tight, and it's not that often I have to do it, but we'll just have to balloon so we can get the device through. Now once you get to the funnel, which you can see that my coring element just entered the funnel in the sheath, you relax the device all together. Pinch the buttons for me there, Jackie, and we'll pull out. And we probably won't get a lot because most of the clot is above where we were pulling. And we'll just need a balloon so we can get through. So I'll take that balloon. This is just a 1040 Atlas balloon. These tend to cross very easily through stenosis, vein stenosis, but they're also very nice at entering stent that you've already placed in the vessels. So we like these balloons. Like I said, not often I have to balloon before I take the device up. But I saw on CAT scan this was pretty tight. And certainly crossing it was a little bit of a challenge. So you may feel a lot of pressure in your back and belly, okay? Now we don't want the clot to get, the May-Thurner is actually protecting her. It's preventing the clot from going to her lungs, and so that's why we don't want to be too aggressive with inflation. Go ahead. But we need to make room. Look how tight that is. Push, push, push. Now crank it up to 6. So we often just push until the balloon's inflated, and then we usually go to 6 to 8 atmospheres. Down. Good. All right, let's take this out. So now follow me up. So now I have the radio-opaque marker past the clot, so I know that my coring element will end up past the clot. And we'll watch it go up. Hold the wire. Okay, follow me up. Yep, up. All the way. So you can see how far this travels. I mean, it goes all the way up through the heart. Okay, switch spots in there. Hold a hand right there. Just hold it, yeah. So I can bring this back without losing my wire. Good. Now we'll come back down. And come here. Now on the screen, I'm going to take a snapshot of this, but you'll see my coring element open in the vena cava. So now we know we're above that clot, and we'll pull back through this. All right, hold the sheath for me. Now, with Hermé-Thurner, we may have to relax it through the common iliac vein. There's not a lot of clot there anyway. It's fibrotic and stenotic. The clot we want to capture is in the external. So if it gets really tight, I'll relax it. Now I have ballooned it, so that may help us. Yeah, it's super tight, so we'll relax it a little there. Then we'll open it back up. It's going to pull on you, dear. I'm sorry. That's what I was talking about before we started. That's a normal feeling. I know it's uncomfortable. You tell me if it gets too bad. Perfect. Now that I'm in her femoral, she doesn't have clot there, so I'll just relax it. All right, now you're going to see us pull the device into the funnel. I'm fully relaxed. Pinch the sides. Good. Perfect. All righty. Now, we're going to show you how to clean this device. So, open up on the back end. So the first thing we do is we open it up. You can see the clot that's in the device. Now I like to dehydrate it, get some of the fluid out of it. And then there's different ways to do this, and everyone has their own method. And I like to flick the clot out, which often hits everyone around the room, so they all move back. The fresher the clot, the more acute it is, the more sticky it is, and the harder it is to get out, actually. So that's all I do is I just flick it out of this sock. And it doesn't have to be perfect. You know, every piece doesn't have to come out. Good. There's a little piece in there. That's not going to matter. So then we recapture the device. So she relaxes the device on the back end, and then we advance the catheter back over the device to capture it. We make sure there's no clot that's squeegeed out the end. And then we're ready to do another pass. And we'll probably do 3 of these passes, and then we'll look. All right. So once again, we follow our radio-opaque device up past where we think the clot is. Then we advance the inner catheter that has the coring element on through the external catheter. And then I like to watch that go through the heart, because I think that's the only way you could really hurt somebody if your wire came back and you advance it through the heart without a wire there. So I watch it go. Then you connect the inner catheter and outer catheter here on the back side. And that just screws on. Then you come back down to where your coring element's located, and you open the device. All right. Now I may have to relax it again, but I'm going to try not to. All right, you're going to feel pulling. I'm sorry. I know that's uncomfortable. And so, you know, with pain medicine, it's tolerated, but they can feel a significant pull through their pelvis. And you try and go slow with the device. But when there's a tight stenosis, it usually will jump on you just a little bit. And again, I pull it all the way back to the funnel. I make sure it enters the funnel. And then I'm fully relaxed here. And then Jackie will push the buttons on the sheath so we can exit the sheath. And then we'll clean. There you go. And I don't know if you can see the sheath here, but I always like to bleed back, make sure I still have blood flow out of my sheath so that it's not, I know it's not fully clotted off as I pulled the clot back. Now, the side port on the sheath allows you to aspirate and potentially pull any clot you've collected into the sheath. And there's probably some clot there because it's not pulling and filling the syringe. Now you can take the sheath out and flush it at that point. I personally think that's not all that helpful. As long as you have bleed back here, you eventually capture that clot and it comes out. So I want to take a picture. I've done 2 pulls and we didn't get a lot on that second pull, so I want to go up and see how much is still there. I don't want to pull my wire out that's positioned for another run, so you can take a catheter next to it. And so I have a Navicross catheter just kind of bare-backed next to my wire. And so we'll go and see what's going on up here. You can see there's just not any clot left in there. Just shows you how efficient the device is. You know, it really only took 1 pull because I didn't get much back after that. But we do have significant narrowing. And that's the May Thurner that we need to fix. So I'm going to look a little lower. I'm going to take a picture just below where the profunda vein comes in, which is almost always at the lesser troch. It looks pretty good. You can see the profunda coming in. And the outflow is a little impaired because we have stenosis, not because of clot. Now we're going to IIUS, and we'll see on the IIUS how much residual clot is actually there. What I found with the Inari device is that there's usually not much of anything that's left. All right. We're also going to use our IIUS to determine what size stent we need, where we need to place it proximally, or should I say centrally, and how far it needs to extend peripherally. It's interesting. There's just no clot left there. Okay. So first thing I'm going to do is a quick run to look at the clot. If we can record. And we'll see our May Thurner again right there. And there's the tight stenosis. And you can see that though the vein right there is fibrotic, there's no clot left in this vein. Bookmark that for me. Good. Now I'm just checking the whole femoral vein. And so often there'll be some right at the sheath, which we can deal with at the very end. Looks good, actually. Stop recording. So I think it's appropriate to be meticulous about the sizing and the placement of your stent. Yeah, I think I'm going to take a 14. Let's take, if you could get me a Vici stent, 14 by the longest we have, and then I'll probably have to extend it, but we'll see what it looks like. We're going to give a little more heparin. Now, she's had a heparin infusion running the whole time, which is how I like to treat. I don't like to shut it off for venous procedures. And then I'll keep the heparin infusion running post-procedure, and we'll be able to remove access in the lab. It won't be a problem. And then tonight I'll give her a shot of Lovenox. Now this is a designated venous stent by Boston Scientific. It just became available this year. It's closed cell. It's highly flexible. It's got good radial strength. We used wall stents forever to stent these severe iliac vein lesions, but the problem with wall stent is they can foreshorten, or excuse me, they can elongate, and then when you balloon them, they shorten, and you can end up missing your lesion. So it's, you know, we've really enjoyed having dedicated venous stents for this. So I like to balloon to stent size. So we're going to balloon with a 14 Atlas before we put the stent in, just so we get good expansion. Look at that. You can see the waste from all the fibrosis she's had in here. You know, this has been going on for a while. The clot is new, but she's had venous disease for a while. You're doing great. Alrighty. So the VG stent deploys similar to a wall stent. It's a pin and pull. It'll be a little difficult to get it started, but after that it deploys very nicely, and it stays put. There we go. Okay. I'll step this out and make sure we don't catch on the stent as we come back. Good. I'll take that 14 Atlas again. Now we're just going to post-dilate our stent, and then we'll IIUS, and we can decide if we want to extend all the way to the common femoral vein. I don't think we absolutely have to. We'll see what it looks like. Now, if we do extend, it would have to be a wall stent, because that's the only stent we feel comfortable taking across the inguinal ligament. All right, going in with the intravascular ultrasound. Good, record. All right, so we're starting in the vena cava and working our way down. And first thing you want to do is make sure you got the May Thurner. And we're entering our stent now, so we know we did. That's the iliac artery crossing over. There's some mild compression on the stent, but it's not bad. You can see the stent's wide open through here. And then we're going to transition down to normal external iliac vein. You know, it actually looks pretty good. It doesn't look diseased. You know, I'm hesitant when I see that to put more stent in. We'll see how it looks on venogram. We can step, so you can stop and step this out. It's excellent, obviously, outflow through there. And obviously we crossed the May Thurner. That negative subtraction is the other iliac vein filling the vena cava. We're not touching the other wall, it looks like. So now let's see what it looks like below. I think this is an important picture, the inflow into the stent. What keeps stents open are good inflow, good outflow, and good expansion. So if you have all three of those things, the stent is very likely to stay open. And there's some narrowing there. Good, breathing normally. So we see on venogram some narrowing of the iliac vein in front of the stent. So peripheral to the stent. So the question is, does she benefit from having that covered? Maybe. I'm going to re-IVUS it. All right, so I'm just investigating. God, the vein looks just small. And then when we come into common femoral, it gets bigger, kind of mid-femoral. Yeah. We should stent it. Just take this out. Give me that 1690 wall stent. I think it's the right move. There's no negative. There's no downside. There's only a top side. All right. Now you want to overlap these stents a good ways. So even though 90 may seem long, it's going to end up being perfect. Yeah. No. It's okay. This is going to end up where I want it. It's better to be more overlapped. You know, it's better to be too much than too little, I should say. So if you look, as long as we end up somewhere down here below the femoral head, it's going to end up being perfect. Oh. Something like this. All right. All right, hold real still for me there. I'm going to finish up. This is going to end up perfect, I think. Bam. Yeah. Sorry, Jackie. I'm just going to save that. All right. We're going to step this out. And then we're going to balloon one last time and take a final picture. It should look beautiful. 14. I think that's the right call. There was, you know, the vein, even though it didn't look diseased, it was narrowed. And you just hate to have any narrowing leading into that stent. So, again, just to summarize, you know, we had iliofemoral DVT. She got heparin for 24 hours. It cleaned out her femoral pretty nicely, but she still had iliac vein DVT. The cause appeared to be a severe common iliac vein lesion from May Thurner. One pass of the Inari device, and it was completely free of thrombus. So that involved no lytic therapy and the risk associated with lytic therapy. It was a one-day procedure, which we're going to do in a little over an hour, so no relook needed, and we're able to fix the iliac vein lesion all in the same setting. So a very efficient way to treat this. And rather than calling her a unprovoked DVT, we know what provoked it. We fixed the problem, and she should not require lifelong blood thinner. So that's a huge benefit to her. Go ahead, Jackie. You can go up. I'm going to go in a little bit more. Yep. And I should say, you never want to jail a profunda vein when you're stenting. So it's fine to cross an inguinal ligament, but you never want to come down past the profunda vein. It's the lifeline to the leg in the arterial and the venous system. All right, yeah, you can step it out. I think it's important to get in the habit of always performing IIUS. After every stent, before you finish your procedure, you should look at the results on IIUS. Venogram can be very misleading. Yep, perfect. Much better, you know. I love it. Okay, stop. That's what you want to see. Good. Breathe normally. You can see all branches coming in below our stent, so we didn't jail anything. That narrowing's obviously gone. So let's pan up. And you see that the dye exits very quickly from the iliac system. So it's just a fantastic result. Again, one procedure, no risk of lytics, minimal blood loss because the Inari ClotTriever pulls clot. It doesn't pull blood. The only blood you lose at all is bleeding back from the sheath. And just super brisk outflow despite her holding her breath. So that's excellent. Good job, breathe normally. We're all done.